Our next speaker is Dr. Patty Ng, the founder of 1060 OBGYN, a private practice in New York City. She's a lost mom herself and is passionate about helping other lost moms and their families navigate their subsequent pregnancies. And we are thrilled that Dr. Ng was one of the first physicians that we spoke with who is interested in starting her own Rainbow Afternoons in New York City.
Hi, good morning. Today I'm going to talk about the challenges to caring for lost mom. My name is Dr. Patty Ng. I'm the medical director at 1060 OBGYN. I'm also a lost mom, so I'm particularly passionate about establishing quality care for fellow lost mom. So when I think about challenges of caring for lost mom, I think of it as three different categories: medical, psychological, and social. One of the most important things we need to do in order to care for lost mom is getting the medical history. I think it is important for us to get a comprehensive medical history, family history, and of course, the history of the previous stillbirth. And the talks from Dr. Cohen, Dr. Wibby, and Dr. Thompson really illustrate the complexity that can go into the investigation of finding a cause for the previous stillbirth. It is challenging for the OBGYN because we need to be sensitive when doing these interviews, but at the same time, we need to be thorough. We need to dig into old wounds and investigate into the etiology of the previous stillbirth by obtaining placenta pathology, autopsy if available, and any pertinent laboratory results. This can be especially challenging for the patients because they have to relive the tragedy. And more often than not, there will be complex medical issue that needs to be worked up. There might be issues that require close follow-up. We should expect to work with multiple specialists such as maternal fetal medicine, psychiatrists, and other medical specialty like hematology and endocrinology. We need to keep an organized chart to help coordinate the care of all these specialists to keep track of what is done, what is missing. And it is sometimes challenging to condense all the different opinions from different consultants and coming up with a plan that is best for the patient. If the patient had a loss and is considering trying to conceive again, there is a need to establish care in anticipation of another pregnancy. We need to investigate if there are any diagnostic work that needs to be done prior to another pregnancy, any medication that needs to initiate in order to optimize the care for the next pregnancy. We need to see if they need a thrombophilia workup, parental genetic testing, infection panel, hormone levels. And we might want to discuss if there's a need for REI, reproductive endocrinology intervention. If the previous stillbirth is due to a genetic disorder, offering the option of PGD might be important to discuss. And some patients might prefer going through fertility treatment to avoid any unknown or uncertainty with the next pregnancy. And as you can imagine, all these counseling, coordination of care, diagnostic testing will require their office visits to be much longer. Besides from longer visits, the frequency of the visits might also be increased. On top of the regular prenatal visits, they will need visits to the specialist and different consultants. These patients might also need additional reassurance sonograms. They might need to utilize triage at the hospital more frequently for decreased fetal movement. Just like Dr. Flores-School said, anytime anybody with decreased fetal movement, we need to address seriously and listen to them. So there's going to be a lot of times where we are sending these patients to the hospital for triaging. So it is a challenge for a busy OBGYN practice to make sure that we can provide these patients with these same-day emergency visits and attention. So the other challenge is the difficult decision on timing of delivery. As an OBGYN, we know that babies born after 36, 37 weeks often do very well and might not require any time in the NICU, and they go home very healthy. But for a patient with a previous full-term demise, there is the stress of prolonging the pregnancy past 36 weeks for both doctor and the patients themselves. In cases that the cause of the previous stillbirth was unknown, it's actually very tempted for the patient as well as the caring doctor to just quote unquote get out at 36 to 37 weeks. The challenge is on the physician to come up with a plan and balance the risk benefits and finding the optimal timing of delivery for each individual patient. Then finally, the route of the delivery is another challenging decision that we need to discuss with these patients. Many of these women lost faith in their body and to give them a healthy baby. They will doubt and might want to do a C-section instead because they feel that it is the safer and more controlled route. And if vaginal delivery is not contraindicated, we might need to consult them and give them more confidence and reassurance that they can do it. However, most importantly, I think we need to provide them with the appropriate counseling and respect the decision once they have been fully counseled. A lot of these women are afraid to do any planning or think about what happens after the birth. They want to get to the delivery day and know that they are taking home a baby first before thinking about anything that happens postpartum. They might not be prepared for breastfeeding. They might not be prepared for the psychological challenges that can happen postpartum. So keeping that in mind and having the appropriate consultant, like a lactation consultant, that can be readily available for them might be very important. And making sure that they continue to have a support system postpartum and not just during the pregnancy. So next, I want to talk about the psychological challenges. Most lost moms are more likely than not had quality medical care with their pregnancy that ended with the loss. The fact that their pregnancy ended with a loss despite adequate medical care will make them lose trust and faith in their doctor and in medicine in general and in the healthcare system. So rebuilding the doctor-patient trust is very important, but very challenging. I find that a lot of times they are looking for a doctor that they feel will listen to them and that will incorporate them into the decision-making process. Sometimes they might sort out a different physician for their subsequent pregnancy, not because they didn't like the doctor, their previous doctor, but because they want just a different pregnancy and a different ending this time. There's going to be increased anxiety when dealing with a pregnancy after loss. Managing the anxiety is a huge part in caring for lost mom. We need to anticipate anniversary, the gestational age that the stillbirth happened last time, the day they delivered their stillbirth, and also symptoms that they had when they realized something might be wrong. And it is important to note in the chart and to understand the patient's behavior and the need for extra support around those times. We also need to ask open-ended questions to understand what the triggers are for the anxiety. And often we will need to work with a therapist, psychiatrist to get through these tough times. Lost moms also often have difficulty bonding with their current pregnancy. They might not want to be too attached to their pregnancy, not knowing if it will end with a live baby. They might not want the sibling or family members to be too attached to the pregnancy so that they won't be too disappointed if something bad happens again. And this is something that we have to address and to reassure the patient that it is okay to be happy about the pregnancy and to have hope and anticipate the future. There is a need to reassure these mothers of fetal well-being at each of the prenatal visits. They should be encouraged to voice their concerns. The most important challenge that these lost moms face is not being heard or the fear of being dismissed. It is important to let them know that there are no silly concerns and that any concern they have will be addressed seriously. I always tell these moms, trust your instincts. And if you're worried, then we should address it. It's never bad to be too careful and it's never a bother. Another challenge that there is a major hesitancy in medication initiation with these patients. As their doctor, we need to emphasize the need for necessary medications such as baby aspirin, vaccination, antibiotics, and when needed, and be ready to analyze the risks and benefits. For example, many lost moms might require SSRIs to manage their anxiety, but doesn't want to take it due to the potential risk of these medications to the baby. We need to emphasize that ensuring the health of the mother is important and foremost to ensuring the health of the baby. Now, even after a successful delivery of a live birth, previous lost moms are at risk for postpartum depression and anxiety, and new grief might surface. So the challenges in our care doesn't end after the delivery of the live birth. Now, lastly, I want to briefly mention the social challenges that we encounter when caring for lost mom. There are cultural differences when dealing with previous stillbirth and grief, and we need to take that into account and be open-minded about other culture when caring for these women. I find that using less presumptive or more open-ended questions in these instances are very useful. We need to be sensitive with their subsequent pregnancy regarding the birth preparation. Some patient might not want to announce their pregnancy and might not want to do any birth preparation at all. For example, in some culture, it is considered bad luck to name the baby before they're born or have anything for the baby in the house before the birth. So we need to take care in listening to their preferences and respecting these preferences. Finally, one of the biggest challenge that OBGYNs, especially in private practice, face when caring for lost mom are the financial challenges for both the patient and the practice. The extra prenatal visits, sonograms, fetal testing, extra hospitalization, the extra triage visits might not be all covered by the insurances. For example, many times these reassuring sonograms in the office are not paid by the insurance company, and the patient might end up having to pay a large portion of it because they're denied by the insurance, or the physician might not get reimbursed for the extra visit that are deemed not medically necessary. And dealing with previous loss is already a difficult enough situation, and it adds to the frustration to know that financial burden can add to the already challenging situation. And all these challenges I mentioned goes to emphasize the need for foundations such as Push for Empowered Pregnancy and the specialized clinic like the Rainbow Clinic that are set up to help these lost mom and their family navigate their next pregnancy. I hope one day we can eliminate stillbirth once and for all, but during the meantime, I hope we can raise awareness to physicians all over the world to take extra care and time in guiding our lost mom through the next journey of hope. Thank you.
Thank you so much, Dr. Ng. That was amazing. And you so perfectly summed up the experience of pregnancy after loss and what families need to get proper care during that difficult experience.